Okay, welcome back. And again, I really want to thank you for all attending today's webinar. The topic is laser therapy versus shockwave therapy for the treatment of lateral epicondylitis, or tennis elbow as it's more commonly known. My name is David Kanashko. I'm a chiropractor. I've been here at Meditech for over a decade, and I specialize in photobiomodulation or low-level laser therapy. My background is in molecular biology, molecular genetics, prior to chiropractic college as well. And my goal with today's webinar is to educate everyone with respect to tennis elbow. Obviously, this will be a review for everyone out there. Some of the latest research with respect to the pathophysiology of this condition, the standard treatments used for tendinosis at the lateral elbow. And then specifically, I want to talk a bit about shockwave therapy. I won't go into a lot of detail because obviously this is more of a laser therapy webinar, but I will talk a bit about shockwave because I know it's commonly used by physios and chiropractors and other healthcare practitioners, and compare them because a recent paper came out that compared the two, and I thought it was quite interesting. That's kind of what ended up why I decided to do this particular webinar. And then I'll talk about research specifically on laser therapy and tennis elbow, and then I'll get into how we use our BioFlex devices to treat both epicondylitis and tendinosis at the elbow. The webinar is recorded, so you can watch it at another time if you have to leave early or if you want to watch it again. I try to reference wherever I can, and you'll see those references documented as I go along. Okay, so I'm going to start off with anatomy and pathophysiology overview, and then I'll get into a little bit about standard treatment for tennis elbow. And then I'll talk about the role of photobiomodulation or low-level laser, low-level light therapy. I'll introduce shockwave therapy, just briefly about what it is and sort of how it works. And then I'll get into the research, specifically meta-analysis on shockwave and tennis elbow, and then meta-analysis of laser therapy and tennis elbow, and then comparing shockwave versus photobiomodulation paper as well. And then I'll finally get into how we target and treat this condition with our equipment, BioFlex low-level laser therapy devices. Again, being a review, won't spend a lot of time. We're all pretty familiar with the ligamentous structures in and around the lateral aspect of the elbow, whether it's an annular ligament, accessory collateral ligament, radiocollateral ligament, the capsule, or the lateral ulnar collateral ligament. These are all important structures around the elbow. It's important to understand the differential diagnoses, of course, when you're treating the lateral elbow, and I'll talk about those very shortly. Of course, we're most concerned with the musculotendinous junction of the extensor muscles at the lateral epicondyle. That's, of course, where the issues that we're talking about today with respect to tendinosis and epicondylitis. One of the major muscle groups involved is extensor carpi radialis brevis, or ECRB. The pathogenesis is quite interesting. We do know that when there's tension applied to a tendon over a period of time, this actually increases cross-linkage, and collagen deposition. So the diagram I've showed you is that on the left side, the cross-linking of collagen, if there's fewer cross-linking, it makes for a weaker structure, a weaker tendon. But if that tendon is constantly under stress, then you get more of these cross links and make that tendon actually much stronger. So it's really important that tendons are used constantly to maintain their strength. And this is one of the issues with tennis elbow, is that because it tends to be a chronic problem, many patients don't use their hand very much, and the tendon becomes weaker, and you get less of this cross-linking. So it's really important to understand this for helping these patients get better. Tendons themselves can stretch fairly easily in response to gradually increasing forces. However, if the stretch exceeds the tendon's tolerance, then it can actually cause a tear or a micro tear to occur. And if you get repetitive or multiple micro tears over a period of time, this can lead to degenerative changes within the tendon itself, and that's what's referred to as a tendinosis condition. Painful symptomatic lateral epicondylitis conditions usually result in underuse of the tendon, as I mentioned earlier. And this underuse can lead to progressive weakening, as I mentioned, and increasing the risk of re-injury. So it's a common problem to recur. So you'll find patients that come in, they're coming in year after year over a period of time because they continuously injure the elbow because they haven't properly strengthened the tendon complex. In conjunction with underuse, there's shearing forces that can lead to fibrocartilaginous formation at the insertion of the extensor carpi radialis brevis tendon insertion at the bone. And this will contribute to further weakening of the tendon-bone junction. It was previously thought that tennis elbow was strictly a tendinitis condition, that is an acute inflammatory condition. Histopathologically, when you look at a tendinosis condition, there's actually very few inflammatory cells, that is macrophages and neutrophils. It's really considered to be more of a chronic degenerative tendinosis condition as opposed to an acute inflammatory condition. There are several well-defined histological stages or changes when you have repetitive microtrauma. So initially, when someone is doing, let's say you go out there and you decide to rake all the leaves in fall time, or you take up squash or tennis or whatever it is, and all of a sudden the next day you have an acute tennis elbow pain, right? So this is an acute inflammatory response where you actually get a inflammatory condition. So that's actually referred to as a tendinitis. However, if the microtrauma is sustained, then over a period of time, there's a concentration of fibroblasts. You get vascular hyperplasia, and you start to get disorganized collagen. And over a period of time, this is referred to as tendinosis. So at stage 2, this is the most common stage for which patients tend to present themselves. In stage 1, oftentimes it resolves fairly quickly. But if it's a continuing ongoing scenario where you start to get this microtrauma, then these patients notice that they're having difficulties using their grip and their hand, and they start to come in for treatment. The third stage is a continuous accumulation of these pathological changes, and this can lead to structural failure of the tendon itself. It can either actually tear partially or even completely rupture, depending on the age of the tendon and what that patient is doing. In the final stages, this is where these patients oftentimes have ongoing fibrosis and calcification, disorganized loose collagen, and hard osseous calcification. So this is long-term, months and years of issues at this particular junction. The microanatomy is really interesting. So if you look at the tendon itself, so I've sort of blown that up for you. The cell structure is referred to as a specific type of fibroblast called a tenocyte or tenocyte. And there's also, of course, collagen fibers or type 1 collagen. These are mature, parallelly aligned collagen fibers. The tenocytes or tenocytes communicate via gap junctions. This is really important because these gap junctions allow for the sort of stimulation of producing more collagen and maturing type 3 collagen as well. So when you have mechanical loading of tenocytes, this stimulates protein synthesis, and there's sort of a tugging at the cytoskeleton, and this sends signals to the nucleus of the cell of these fibroblasts, and it can release biochemical signals that increase gene expression and the production of collagen. So we know that eccentric loading exercises are really important in the recovery of tendinosis, whether it's in the elbow or Achilles or what have you, to stimulate repair and proper alignment of collagen. Tendinopathy itself is usually defined as a clinical syndrome. There's usually pain, swelling, and functional impairment. Tendinosis, as I mentioned, is a fairly common degenerative non-inflammatory process. That's really important because the last thing you want is a patient coming in on anti-inflammatories or being injected with cortisone if they have a tendinosis condition as opposed to tendinitis. In the tendinosis, there's lots of disorganized collagen structure, whereas in tendinitis, it's usually more of a rare condition. It's acute inflammatory process due to acute micro-tearing because of overloading of a tendon, and again, usually due to one specific event. If you look at the time for recovery, a tendinosis is usually quite significantly long. In early presentation, it can take 6 to 10 weeks. However, in chronic, it can take many months. Whereas a tendinitis oftentimes resolves if iced and taken care of appropriately within a few days, well, usually a week or 2 weeks. Whereas in a chronic scenario, these conditions, tendinitis, if it's not taken care of, will take several more weeks to improve. In a tendinosis, you want to encourage collagen synthesis and repair, and in tendinitis, you want to reduce the inflammation. Now, laser therapy will be effective in both these scenarios because we know that low-level laser therapy is quite effective in reducing inflammation, but it's also very effective in encouraging collagen synthesis as well. Age is a commonly associated with increased prevalence of these degenerative changes in the tendon, and you start to lose cellularity, so less of these tenocytes, and you start to increase glycosaminoglycan content, and the fibers, the collagen fibers, start to lose their organization and their parallel fiber, or their parallel structure. The aging tendon itself starts to become less elastic and therefore more prone to tendon changes. Any activity that involves excessive or repetitive use, so whether it's tennis, playing an instrument, typing, manual work, that kind of thing, this can lead to tendinosis. Other risk factors that are known are smoking and obesity. Symptom-wise, you're looking at initially intermittent pain related to exercise or activity. Patients will complain of stiffness, especially upon weight bearing or starting to use like gripping, that kind of thing, after prolonged immobility. So they'll wake up in the morning, and as soon as they start to, maybe make their coffee or whatever, they'll notice some quite a bit of stiffness, and this will loosen up and feel a little bit better as they exercise or as they start to engage those specific muscles. As the condition worsens, there will be a progression of the pain that is then begin to experience towards the end of the exercise session to actually pain throughout the duration of the activity. So initially it's after, and then it's at the end, and then during the entire length of the exercise as the tendinosis starts to become more chronic and more severe. A microscopic view of tendinosis reveals that there's an increase in type 3 or immature collagen, an increase in ground substance. So you'll start to see a thickening. You'll start to see, well, if you look at it microscopically, vascularization that seems to be haphazard. And you'll start to see loss of collagen continuity. By that I mean the fibers aren't properly aligned in parallel structure. And they also start to lose their ability to link together, which reduces the ability of these tendons to facilitate load bearing. So a normal tendon, you can see on your left, all the fibers are parallel in structure, and there's actually little tiny cross links that connect them. That's a normal, healthy type 1 collagen in tendons. If you're looking at a tendinosis, you'll see that there's a lot more cellular structure with respect to the collagen, the fibroblasts, this weird sort of looking spider webs collagen. This is what you're looking at in a immature type 3 collagen type of tendon. Again, tendinitis is inflammatory, and you get micro tearing, and this is because of an acute overloading scenario. So, you go out and do something, and the next day you have pain. It's hypothesized that tendinitis is often directly the result of tendinosis. So, for example, you have a patient and their elbow seems okay or whatever, but they're a little bit older, maybe middle-aged or older, and then they start to do something for the first time, raking leaves, playing tennis or squash, and then they start to develop a tendonitis because there's an underlying tendinosis pathology ongoing in that tendon itself because of age or other microtrauma. Diagnostically, one of the key tests to do is, of course, you're looking at pain at the epicondyle of the lateral elbow. If you have that patient's elbow extended and then resist extension, it should be painful at that spot where that blue little dot is. And then if the patient bends their elbow to about 90 degrees and then does the same resisted extension, then that pain should be reduced or even eliminated. So that's a positive test for issues at the epicondyle. Differential diagnosing, you need to be aware. So epicondylitis, you need to be palpating right at that epicondyle and the insertion of the extensor carpi radialis brevis. You do need to be aware of things like osteochondritis dissecans of the plica at the elbow, which is just a little bit distal to the epicondyle. Any issues with the radial head, so palpate through there. And of course, the radial nerve can also be compressed through the ligaments as well. So these are all things that you need to understand and palpate and do your best to make sure you know what you're treating. Chronic tendon injuries are degenerative in nature and not necessarily inflammatory. Keep harping on this because it's important that these patients aren't on NSAIDs or corticosteroid injections. Some of the most recent research, which I've quoted below, actually indicates that you can accelerate the degenerative process in the tendon itself if the patients have corticosteroid injections or taking NSAIDs. And this may actually increase the likelihood of rupture. So the last thing you want to do is have these patients that have a tendinosis condition being referred for an injection or those specific medications, which many, to be honest, many physicians don't recognize that and they'll prescribe it, not understanding the underlying pathophysiology. And that's, of course, where our expertise is. No disrespect to medical doctors, but oftentimes a GP, they're treating lots of different things and they may not necessarily have that expertise in these types of conditions. Tendon healing is a continuous process because a tension across the fibroblast causes these cells to divide and align perpendicular to the line of the stretch. It's important to understand here that tendons can take a long time to heal because it takes well over 100 days to regenerate and make new collagen. So the patient needs to be aware of this when they're coming in for treatment. This concept really has to do with Wolff's Law, and which understands that the tension on maturing granulation tissue may lead to the development of preferential direction of collagen in the fibers themselves. Standard treatment, initially, you're trying to restore a regenerative process. You can do deep tissue massage and trigger point work in the area. Then, of course, you can do transverse friction massage, making sure that you treat the affected area. You can start to improve the functionality and flexibility with respect to active movements and stretching exercises, isometric contraction, and also treatment of the antagonist muscles as well. All of this comes from that same particular journal that I mentioned earlier. Of course, you may want to give some stretching as long as it's not aggravating, preventing overuse. So you need to make sure that they're not engaging in the activity or the sport that makes sense. And of course, proper posture at work, that kind of thing as well. Final phase would be looking at trophic training with respect to muscle strengthening exercises, concentric and eccentric loading exercises as well. The role of laser therapy is such that we know that the research has shown that it can improve collagen fiber organization or helping to improve the parallel alignment. It can increase the synthesis of type 1 collagen due to tenocyte proliferation. It can downregulate matrix metalloproteinase, which is an enzyme that can degrade matrix proteins. And it can decrease inflammation. Again, this is important if it's a epicondylitis condition. It can upregulate IGF or insulin-like growth factor that helps with cell proliferation and matrix remodeling. And it can reduce fibrosis. It's also known to increase reactive oxygen species. These are highly reactive molecules that in short spikes will trigger cell signaling, help the cell cycle progress, enzyme activation, and eventually protein synthesis. Okay, of course, the title of the webinar does mention shockwave therapy. So extracorporeal shockwave therapy exhibits direct effects, again, on calcification of tissues, on cell activity, alteration through essentially cavitation with sound, very specific sound waves, and acoustic microstreaming. It can even alter cell membrane permeability, and it can even help with pain and help control pain on nociceptors. So there's different theories on how it works, but one of the theories is blocking the control of the gate mechanism. There's different types of shockwave. I won't go into all the details of it, but low energy sound waves have more of an analgesic effect. It seems to disrupt the cell membranes, either partially or completely, of the nerves, whereas high energy seems to help with vascular neogenesis, helping with vascularity and reparative cell cycle as well. But it works definitely differently mechanism-wise than low-level laser therapy. Okay, so let's take a look at the research. First, I'll focus one on on shockwave therapy. Well, actually, this particular paper was entitled "Chronic Lateral Epicondylitis: The Challenges and the Solutions." And when they were looked at shockwave therapy, they referenced a meta-analysis. And in that meta-analysis, they found that there were only 2 randomized control trials that showed improvement with respect to pain and function in patients suffering from refractory or chronic tendinosis of the elbow. However, they did make a point of saying that the majority of the other randomized control trials found there was no difference in the outcome between shockwave and placebo groups. In a fairly large systematic review by author Sims et al., they concluded that shockwave therapy may be no more effective than placebo. And I'm not trying to convince you one way or the other with respect to shockwave. What I'm trying to show you is that if you look at sort of the gold standard for meta-analysis and systematic reviews, there is some positive with shockwave, but there's actually more negative with respect to the outcomes of using shockwave and tendinosis. If we look at a fairly large systematic review and meta-analysis of low-level laser therapy and tendinopathy, specifically they looked at 25 controlled clinical trials. 12 showed positive effects and 13 were inconclusive, which you may look at, well, is that very good? It's actually quite good to show that over half of them had fairly significant effects. This particular meta-analysis, they concluded that low-level laser therapy can potentially be effective in treating tendinopathy when the recommended dosages are used. The 12 positive studies provided very strong evidence that positive outcomes are associated with the use of current dosage recommendations for the treatment of tendinopathy. So in other words, if you compare and contrast these two for meta-analysis, over 50% or about 50% of RCTs showed a very strong effect of laser therapy, where a much lower percentage of randomized control trials in meta-analysis showed that shockwave was effective. Now, if we look at this paper I mentioned earlier, this is comparing and contrasting photobiomodulation versus shockwave in the treatment of lateral epicondylitis. They looked at 43 patients. They were randomly divided. 23 had laser therapy and 20 received shockwave. Laser therapy was applied 3 times a week for 4 weeks, and the shockwave was once a week for 4 weeks. Stretching and eccentric loading exercises were also given to both groups as a home program. The results concluded that there were improvements in elbow extension and shoulder flexion strength, and for VAS with movement were observed only in the laser therapy group, whereas improvement of hand grip strength was present in both groups. However, the hand grip strength was superior in the laser therapy treated group compared to the shockwave treated group. So if you look at this particular paper, it's showing you that, yes, Shockwave does seem to have an effect on chronic epicondylitis or tendinosis. But if you're looking at the two head-to-head, low-level laser therapy seems to have a better effect both with hand grip and obviously especially more with pain and movements as well. A randomized control trial on comparing braces, laser therapy, and ultrasound. They looked at 58 patients overall. And in this particular paper, they showed that the brace had a shorter beneficial effect in ultrasound and laser therapy in reducing pain. However, laser therapy was the most effective modality with respect to brace and ultrasound in improving grip strength. Okay, so let's take a look at how we approach treatment. We try to wrap the large surface array around the epicondyle itself. We also do a placement over the muscle extensors. Oftentimes, if there are trigger points, we'll wrap that around. The idea with these large surface arrays is that you're going to treat a lot of blood. You're going to help with the recovery of the superficial structures and the tissues, improve the anti-inflammatory respect of the white blood cells in that area. The laser probe is the sort of the second part of the treatment, and we tend to use the LDI 200 for getting depth into getting the light deep into the tendon and the muscle structures. You can also use red laser probe more for pain in the specific area. Of course, you're going to focus on the musculotendinous junction of the extensor carpi radialis brevis and the common extensor tendon. However, you may also want to treat trigger points or active tender points throughout the extensor muscles, even proximal and distal to the epicondyle region itself. The protocol, we have two protocols here. We have an epicondylitis protocol, and if you look at it, the first step when you wrap the array is 8 minutes long, so it's a little bit longer with the red light, and then we're trying to promote a continuous wave of light coming in. This is going to be very helpful with pain and with microcirculation. Then the next step is using infrared. Notice that it's a fairly low frequency. Remember, epicondylitis, we're dealing with an acute response here. I would use this protocol for an acute flare-up of the elbow, so you know there's inflammation going on. In these cases, you tend to see fairly tender to touch, redness, that kind of thing, and we tend to use a fairly low frequency and fairly low duty cycle because of the acute inflammatory process that's going on. Then we use the laser probe at about 40%, so that's about, I think that's around 75, 80 milliwatts of power if you're interested. 5 minutes total. You're going to hold it in each spot for maybe 5 to 10 seconds per point and see how they tolerate that, and you can increase that time if the patient's tolerating that well. Now, we also have a tendinosis protocol. Again, this would be used for specifically no acute inflammatory phase going on. According to the symptoms and your diagnosis, you're dealing more with a degenerative condition as opposed to an acute inflammatory response. Again, you're going to start with the dual red, helping with the microcirculation and the pain. And then notice that the infrared, we're going to use a slightly more stimulatory at 20 hertz and a much more higher dosage at 70% duty cycle, which is a lot more than the acute epicondylitis protocol. Again, because it's a chronic problem, we're increasing the dosage to try to stimulate more of the cell cycle of the fibroblasts and the tenocytes in the tendon itself. And similarly, for the laser probe, you're going to use it initially at 40% power, again for about 5 minutes, and holding it for 5 to 10 seconds or thereabouts. You can probably hold a little bit longer given it's a chronic kind of scenario. A few tips about using the probe. Make sure that you make good contact with the skin. Don't hold it at an angle because then you'll lose a lot of light. I'm still not a big fan of lasers that don't touch the skin or light that doesn't touch the skin. Up to 85% of light can be reflected off of skin. So to me, it's a complete waste of time and energy if you're not touching the skin and even depressing and pushing in the laser probe into the surface of the tissue itself. Our LDI 200 probe, again, you're going to hold for 5 to 10 seconds or thereabouts to try and get that target tissue. If the muscle is very deep, then you want to go a little bit longer. Once you treat the points around the epicondyle, then you can treat myofascial trigger points and treat those areas and go back to treat the epicondyle again. Again, if you have the LDR 100, which is the red laser probe, you can also use that to help with pain. Initially, especially if it's an acute presentation like an epicondylitis, try to have them come in on 2 or 3 or 4 consecutive days, and then you can go 3 times a week until they're starting to show significant improvement. And then you can go about two times a week and eventually 1 time a week. So remember that if it's a tendinosis, it's going to take weeks or a month or 2 to really start to improve the condition. If it's a acute tendinitis, then it should only take a week or 2 to make significant improvement. Overall treatment plan for a tendinosis condition, you're looking at upwards of 30 treatments over maybe 2 or 3 months. An epicondylitis, maybe 10, 12, 15 sessions depending over a shorter time frame, maybe 2 to 4 or 5 weeks or thereabouts. Remember to address the underlying causes with respect to work, overuse, or sports, that kind of thing. And of course, you're going to be adding manual therapies, exercise. And certainly if you have Shockwave, if you're using Shockwave in conjunction, it may be synergistic. Then I would do the Shockwave first, followed by the laser therapy, because of course Shockwave is causing a mechanical disruption to tissues, and laser therapy can help with the after effects of Shockwave as well. Okay, so I'm going to open it up for some questions, but first I want to mention to everyone that if you're new listening in or you have not yet been certified in the use of low-level laser therapy, I invite you to join us for a full day of online training. It's only $199 Canadian. That is not very much for an entire day of lectures. It's done by myself and Dr. Slaver Kim, our clinical director. It's next Friday, June 19th. It's actually at 9 a.m. That's incorrect. It's 9 a.m. until about 4 p.m. in the afternoon. We register in 8:30 and between 8:30 a.m. and 9 a.m. That's Eastern Daylight Time or Standard Time in Toronto. Go to our website, bioflex.com or bioflex.com/events, and you can sign up there. And also I have a couple webinars coming up in a couple weeks on our personal system used for treatment of neck and back pain. And then I have one more for professional use, specifically for the prevention of muscle injuries in July 9th. These are free. You can register online as well. Okay, so let me get to your questions. I'll pull those out right now, and hopefully everything is good. All right, so let's just see here. We'll get to the questions. And you can type them in right now if you'd like. Okay, I have a question by Dr. Mangoff. How effective are collagen supplements to help in healing? I'm not really sure. I haven't seen really a lot of evidence with respect to collagen supplements. I think if you give the body more precursors to making collagen, I think that will be helpful. I do recommend CoQ10 or ubiquinol to help increase the activity of the mitochondria as far as a supplement goes. I have another question here. I'd like to add a common condition of isometric musculotendinous strain from, for example, holding a cell phone. Oh, yes. Okay. Yeah. So, yeah, exactly. Holding a cell phone and the way you're positioning it, I think that can actually trigger this condition as well, too. That's a good point. What percentage or pulse for red probe? We tend to use continuous wave for the red probe or for any probe. We tend not to pulse it because it's not on one spot for too long. Pulsing doesn't seem to make a big difference if you only have light or laser light on a target tissue for a short period of time. Do I know of any studies combining shockwave and laser? That's a good question. You know what? I don't think there's been one that's actually done that. I know I've seen ones for laser and an ultrasound, laser and PRP. I'll have to check that. Let's see here. Fred mentions bone marrow broth. I don't know much about that, but perhaps. Acute strains will heal faster. Yeah, definitely, for sure. As far as time frame goes, you might be 1 or 2 weeks for that, for sure. So I do have a patient here, or someone asking about a slip disc. I'm not sure I understand that question. Sorry. Is it approved in Canada by most insurance? Yeah, so laser therapy is approved by insurance companies because it's usually performed by physiotherapists or chiropractors, massage therapists, and it would be within their scope of practice, so it should be covered under that specific form of third-party insurance, but not like OHIP or federally funded insurance. So the question about laser therapy and COVID-19, unfortunately, Carlos, I can't really get into that right now. There's been some editorials and some talk about using low-level laser therapy for help recovering from COVID, perhaps, or prophylactically to help improve lung function, but certainly not during the acute phase when the virus is out of control. Would treatment be similar for medial epicondylitis? Yeah, Laurette, great question. I focus on tennis elbow, but just for sake of simplicity, then of course this would be very similar to medial epicondylitis or tendinosis at the medial aspect as well too. Great, thanks a lot everyone. I really appreciate you joining in today. Hopefully you can make it out to the next webinar, and if you have any further questions, you can contact me. My email is david@bioflexlaser.com with any concerns or questions that you have. Thanks again for joining in, and hopefully we'll see you soon. Sign up for the certification training if you haven't done so. It's a great opportunity and a good price, I feel, for a full day of training. Thanks very much.